Hi, everybody. I hope, as always, that you are doing well. Um, Today, we're going to talk about a really complex issue, and the readings and the videos go more into depth. But we've talked a little bit here and there this entire really semester about this, and what that is the American healthcare system. So that's the key topic we're going to go through today, and that and doctor-patient interaction, hospitals, physicians, those sorts of things. So they're important conversations, important things to talk about towards now here as we get towards the end of the semester. But first, just an assignment reminder again that your second paper is due Sunday, April 6th by the end of the day. So make sure that you let me know of any questions you have, any extension that you need to get that assignment completed and turned in. But please let me know of any questions you have at any one-on-one time that you'd like. But let's get into this session for today, the American healthcare system. So really what I want you to understand by the end of these readings, by the end of this session is the structure and challenges of the American healthcare system and the nuances here and the unique challenges that we're facing. I want you to be able to analyze the dynamics of doctor-patient interaction and and really apply sociological imaginations and look at the sociological implications of these dynamics. I want you to also be able to understand the organization, the roles, and the social hierarchies within hospitals. And then I want you to be able to critically examine and discuss how access to medical education and physician shortages, for example, help to shape healthcare delivery. So first, just as an introduction to the American healthcare system. So let's just start with a foundational understanding of this system and its structure, its key challenges, and how it compares to other healthcare systems in other countries. So first, let's take a look at the US healthcare system. So there are four key explanations here of what the American healthcare system is, just kind of key descriptors here. And we'll get into actually some others in following slides. Let's first talk about the fragmented structure of the American healthcare system. So the US healthcare system is really unique because it operates as a multi-payer system. So that means that there are multiple sources of coverage, like private insurance, Medicare for the elderly populations, Medicaid for low-income individuals, and other government programs. There's a significant majority of Americans that don't understand the difference between Medicare and Medicaid. But this and then that dynamic with private insurance. So think about this: how multi-payer system, meaning that there are various ways to pay for medical costs. That includes your private insurance, even those you might get through your employer. Medicare for elderly populations and Medicaid for low-income individuals. And there's also some other government programs. Think of for veterans, right? Veterans Affairs, the VA, hospital systems. But the key point here is that this fragmentation of our system leads to various inefficiencies, such as overlapping services, higher administrative costs, and difficulties in coordination between providers, ultimately contributing to inequities and high healthcare costs. So really, I think, like, contrast this with countries that have universal healthcare, for example, like Canada, many other countries in the world. These universal healthcare systems where a single payer, which is usually just the government, finances healthcare for all citizens. So there's a greater efficiency. You save in administrative costs. You save in general costs on the economy because people aren't paying out of pocket for their healthcare coverage. So think about in contrasting these different models and why is it that the American model has stayed this way and persists this way. Number two, high cost and unequal access. So here I want you like referencing the Barkin reading, I believe chapter 12. So highlighting that healthcare spending in the United States is much higher than in other developed nations. Yet the system that we have in the United States leaves millions of Americans uninsured or underinsured. So think about that we spend more in the United States, but we also leave more people uninsured and underinsured. So that's a key disparity there. And so this high cost of healthcare, including high premiums and copays and out-of-pocket expenses, this limits access to care for many, many people, especially those in lower socioeconomic brackets. So think about how this creates disparities and exacerbates disparities. Remember, we talked about it. Socioeconomic status is a critical social determinant of health. This is a key reason why, especially in the United States, as we think about who has access to care and can actually afford medical care. Number three, healthcare as a commodity. So the United States treats healthcare primarily as a market commodity where supply and demand dynamics are taking place. And really supply and demand in US healthcare shapes who receives care and what kind of care they receive. So in this model, healthcare is often considered a service, right, that must be paid for rather than like, say, a basic human right or a public good that our governmental institutions can provide. So considered a service, a pay-for service, rather than a right or a public service. Really, and as a result of this market commodity of healthcare, people with higher socioeconomic status are much more likely to have access to better care, while lower income individuals may face more significant barriers, all those that we've talked about before. And this contributes to widespread health disparities. So again, contrast this to countries with universal healthcare like the United Kingdom or Canada, where healthcare is viewed as a public good, typically fueled through taxes, and access is really not just based upon ability to pay. It's based upon, are you a citizen and are we providing this resource? And then implications for medical rationing here. So kind of thinking more about the Jenkins and Reddy reading here, where they discuss how medical education and the supply of physicians, for example, is rationed, especially in rural areas where there is a shortage of healthcare providers. We're experiencing this and continue to experience this, that great shortage of healthcare providers and physicians in more rural areas. And so the high costs of things like medical education, this limits the number of medical school spots. This limits and also adds to the lengthy training periods of physicians, right? These sorts of things create barriers to actually entering the medical profession. And so this results in a shortage of physicians, but especially a shortage of physicians in underserved areas, contributing to healthcare access inequalities and the cyclical nature of these types of healthcare disparities that we've talked about. So really, I want you to be able to have and solidify this critical understanding of this US healthcare system and the fragmentation of it, because it's really critical to understand the administrative fragmentation, the service, the cost fragmentation, and how that creates burdens on not just service provider, but the service receiver receiving healthcare. And so we'll look at the challenges that the system faces and the disparities that arise from this market-driven approach. So I just want you to learn about the systemic barriers to the things I mentioned at the end there, the barriers to medical education and the implication of these issues on healthcare access in various populations. So think about, what are the primary advantages and disadvantages of a multi-payer system like the one in the United States, right? What are the advantages? What are the disadvantages? Be thinking about that as a through line. And I'd be curious to hear from you all on that. So the American healthcare system. So let's dive even a bit deeper than the previous slide here. So just overall, from a medical sociology perspective, the American healthcare system is a really complex and fragmented structure that reflects broader social inequalities, political ideologies, and economic interests. So unlike many other developed nations, the US operates a multi-payer system, like I've mentioned, combining private health insurance, employer-provided health insurance, and government programs like Medicare, Medicaid, and Veterans Affairs Assistance. And so medical sociologists examine the system through several key lenses. We look at access and equity, we look at cost, we look at the commodification of healthcare, we look at all of these key components as we're looking at this system and trying to analyze it critically from a sociological lens. So you see some key elements up here that we're going to look at, 1 through 5 there. We're going to actually get into them specifically in the following slides. Let's start with access and equity. So the American healthcare system is really characterized by disparities in access to care and really heavily influenced by factors like socioeconomic status, race, geography, employment. And so, for example, I've listed there some key areas. So socioeconomic barriers. So in the United States, those with higher incomes are much more likely to have access to comprehensive healthcare. Yeah, often through employer-sponsored insurance plans. Meanwhile, lower income individuals much more often rely on government programs or may lack coverage altogether, having no insurance coverage at all. And this leads to things like unmet health needs and poorer health outcomes. If you're not going to the doctor for things like preventative visits that you can get for free for free through most health insurance plans, when you're going to the doctor for those sorts of things, you can be more proactive. But when you don't have coverage, inadequate coverage, you have unmet needs. And racial and ethnic disparities as well. So medical sociologists highlight persistent inequities in healthcare access among racial and ethnic minorities. So historical discrimination and ongoing structural barriers, the things that we talked about, remember in the racial segment, the race and health disparity segment in the course, think about those things. That means that people of color are less likely to receive preventative care and more likely to be uninsured and more often live in areas with fewer healthcare resources. There's also rural versus urban access. I kind of mentioned this a little bit earlier, but geography also plays a key role here. So as rural areas tend to have fewer healthcare facilities and providers than urban areas. So this results in medical deserts that we call them. This is where residents have to travel long distances for care. As someone who grew up in a very small town in South Dakota, this is very evident that rural healthcare providers, there is a key shortage here, and it causes these medical deserts. Or to even just receive preventative visits, preventative care, or surgeries, you might have to travel potentially significant distances to receive that care versus the experience of people in more urban areas. The second area here that I'm going to look at is the high cost of care. So medical sociology explores how the high cost of care impacts individuals and families and society. So first, healthcare as a commodity. In the United States, healthcare is treated, like I mentioned, as a market commodity rather than a universal right or some public service. This means that healthcare services and insurance and pharmaceuticals are profit driven with high costs that can create financial strain or lead to medical debt for individuals. And this also is important to talk about rising premiums and deductibles. So while private insurance is quite common, especially through employers, these plans oftentimes come with high premiums and deductibles that make healthcare financially burdensome, even for those with insurance. So do we understand what we mean by premiums and deductibles? So premiums are that monthly payment that you're going to pay for your health insurance, whether the employer is paying all of it or even just part of it, and you're paying part of that monthly premium. Those premiums are quite high and most often are rising and quite high. And deductibles are, let's say, I want to not have a high premium, so I've got a higher, so I pay a little bit lower premium, but I've got a higher deductible. A deductible is the amount of money that you are eligible to pay out of pocket, your out-of-pocket deductibles for healthcare coverage. So even though you're paying this monthly premium, there's still, whenever you go to the doctor, you still have to pay a certain amount because there's a deductible as well. So let's say I have a high premium, but I've got a $3,500 deductible. Well, I got to pay up to that $3,500 deductible before everything is actually covered. And then there's in-network and out-of-network issues where it's very confusing and fragmented of what your insurance actually covers and where your insurance covers certain treatments. So medical sociologists here argue that the high cost here deters individuals from seeking timely care, which can worsen health outcomes. And then prescription drug prices too. So the United States has some of the highest prescription drug prices globally because pharmaceutical companies have more freedom to set prices and even advertise on television. So the issue here highlights how the profit motive in healthcare can really directly impact individuals' access to necessary medications. We're one of the only countries other than Australia where pharmaceutical companies can actually advertise on television. And even for this, we pay hundreds times more for the same drugs in the United States that other countries do for the same exact medication. So there's clearly a disparity there in this profit-driven model. 3, the commodification of healthcare. So medical sociologists largely critique the commodification of healthcare, whereby health services and outcomes are increasingly influenced by market forces rather than public welfare. So you see listed there some examples like for-profit hospitals. So many hospitals in the United States operate as for-profit entities, and this emphasizes they emphasize high revenue services like really specialized surgery. Remember we talked about medicalization and the specialization of healthcare? It's more costly there. And they oftentimes emphasize those high revenue specialized services over general or preventative care. And this focus on profit can lead to a lack of resources for underserved communities were less profitable, but essential services are really needed. So again, that commodification, lack of an emphasis and access to the less profitable, more preventative general care. and insurance companies and profit motive as well. So insurance companies really aiming to maximize profits may limit coverage, restrict access to certain providers, or charge higher premiums. And this creates an environment where healthcare is not evenly distributed, but instead favors those who can afford better plans. So think about the just this year, the drama going on with the health insurance industry, with the United Health CEO being murdered. Because there's a lot of conversations that started of, well, these insurance companies do a lot of bad things, will purposefully deny people coverage that they actually are supposed to be covering because they know those people just accept it. And there's a lack of a challenge procedure there. So there's significant issues with the for-profit insurance model, because when you're for-profit, you're going to try to limit expenses, but also create bigger revenue, obviously, right? That's the whole model. And so by limiting expenses, you want to cover less, you want to pay for less, and you also want to charge more. And that's increasingly an issue. Gatekeeping and access as well. So insurance companies act as gatekeepers, oftentimes requiring pre-authorization for certain treatments or denying coverage based upon cost considerations. And this really does limit patient autonomy, your autonomy to make that choice, and adds bureaucratic obstacles for accessing care. So this commodification of healthcare has all these issues and more that highlight why this is a problem in the U.S. healthcare system. The fourth point, sociopolitical influences on healthcare policy. So medical sociology also examines how political ideologies and policies shape healthcare access and quality in the United States. So thinking about the political divide on healthcare as a human right. So there's this constant debate that you're going to hear about more and more. You constantly hear about it over healthcare as whether it's a public right versus a private responsibility. And this reflects broader political divides, right? Because while some policymakers advocate for universal healthcare systems in the United States, others support the market-based models and emphasize personal responsibility for health. And Medicare and Medicaid here as well. So these government programs, remember, describe the differences of them. These government programs aim to support the elderly and low-income individuals and disabled people living with disabilities. However, they are often underfunded or politically targeted for things like budget cuts, limiting the quality and scope of care that they can provide. If you look at our national debt, one of the things that is causing our deficit is the cost of healthcare, is the cost of Medicare and Medicaid. And so it's constantly threatened with budget cuts. But then what is the alternative? If we don't offer these things, how do elderly and low income and people living with disabilities, how do they receive the coverage that they need? And then healthcare reform efforts as well. So sociologists, and particularly medical sociologists, study attempts to reform the U.S. healthcare system. Things like the Affordable Care Act, which aimed to expand access to insurance. The Affordable Care Act really faced both political and ideological resistance, and it underscored, if you read about that, and there's readings here and videos for the day, it underscores how difficult it is to achieve those types of systemic changes in profit-oriented systems, particularly like profit-oriented healthcare models. So moving on to number 5, the role of medical education and professional shortages. So finally, sociologists also examine the limitations of medical education and physician shortages, particularly when we look at rural and low-income areas and the rural-urban divide here. So medical education and debt. So training for healthcare professionals is quite costly, and this leads to higher levels of student debt, another area in socioeconomic conversations that is increasingly troublesome and difficult. And so this influences career choices, as many new doctors opt for higher paying specialties in more urban areas to pay off those sorts of debts, right? The high cost of education. So they're going to get into the specialties, neurology or whatever it might be, and surgery, rather and really leaving behind primary care in rural areas, leaving rural areas more understaffed. And then physician shortages and medical deserts. So limited availability of healthcare professionals in certain regions, especially more rural and low income areas. These exacerbate health disparities. So medical sociologists explore how structural factors such as insufficient funding for primary care and unequal distribution of medical resources, how these things contribute to these medical deserts and physician shortages. So just to conclude this section kind of overall here. So in summary, the American healthcare system, particularly as viewed through this sociological lens, is deeply shaped by social stratification, political ideology, and economic interests. And this approach, this sociological approach, highlights how inequities in access and inequities in costs and inequities in quality of care are not just individual issues, but they're actually deeply embedded within broader social and structural frameworks. And so sociologists here argue that addressing these disparities requires systemic changes that prioritize healthcare as a public good, as a public service, rather than its current market-driven approach. So these are ongoing conversations that not just sociologists are having, but of course, people in the political front and the healthcare industry themselves are actually having, but they're critical. And as, again, thinking sociologically, thinking upstream versus downstream effects, we need to address the root causes and systemic nature of this system. Now, moving on to the doctor-patient interaction component. So here we want to explore how sociological factors shape our doctor-patient interactions and what those relationships are like, including things like power dynamics, communication barriers, and the influence of race, class, and gender on healthcare experience. So let's talk through 4 different areas here, and then like before, we'll dive into some other specifics around this topic. So power dynamics being one. So in doctor-patient interactions, there is often an inherent power imbalance because physicians typically hold more authoritative knowledge regarding medical diagnoses, treatment options, all of which can make patients feel disempowered or reluctant to ask questions or challenge decisions of their doctors. And so thinking about the 13th chapter in Barkan, Barkan emphasizes that this unequal power dynamic can lead to patients feeling as though they have limited control over their health decisions, which might affect their engagement with treatment and healthcare providers. Remember, we talked about autonomy and empathy and the importance of in those things and actually having people stand by and adhere to their treatment options. This is a key component, these power dynamics. And so think about the imbalance and how this can result in compliance rather than collaboration, where the patient's voice might be overshadowed by that doctor's authority, reducing empathy and trust. Speaking of trust, number 2 there, communication and trust. So effective communication is really key to building trust in the doctor-patient relationship. However, issues such as the use of medical jargon or a lack of empathy and time constraints, these things can create barriers to effective communication. And these barriers can really hinder the patient's understanding of their diagnosis, understanding of their treatment plan, and this leads to poor health outcomes. So what do we mean by jargon, medical jargon, right? So when we think of jargon, it's the use of very technical and specific language that general audiences, general people do not understand because they're not in the industry. So when you use that sort of medical, very technical medical language and jargon, it can create confusion and a disconnect. And so really, it's important to emphasize that trust is central to the relationship of the doctor and patient. And also this trust can be damaged if a physician fails to communicate clearly or maybe seems to dismiss the patient's concerns. So patients who do not feel understood or respected may have lower adherence to the medical recommendations of their professionals. And across the board, we do see that trend. Number 3, cultural and social factors. So race, gender, and socioeconomic status play significant roles in shaping both the expectations of patients and the biases of physicians. So for instance, marginalized communities, think of like racial minorities, low-income individuals, may experience implicit bias from healthcare providers, or they may have lower levels of trust in the healthcare system due to past negative experiences of discrimination and mistreatment. So for example, maybe a Black patient may feel hesitant to seek medical advice from a predominantly white healthcare provider or healthcare system, fearing misdiagnosis or neglect or a lack of empathy. And similarly, women may be less likely to receive proper pain management due to stereotypes about gender and emotional expression. So these traditional all the things we've talked about in previous sessions, right? These things lead to a lack of trust and barriers based on cultural and social factors. So think about how cultural sensitivity and competency and awareness of these factors can really improve patient-provider communication and reduce those disparities in care. And then finally, number 4, patient empowerment and autonomy. So patient empowerment is a growing focus in healthcare and patient-centered care, where patients are increasingly encouraged to take an active role in their treatment decisions. And this shift emphasizes shared decision-making, where both the physician and the patient collaborate to select the best course of action based on mutual respect and understanding. So patient autonomy here allows individuals to feel more in control of their health outcomes and fosters a better sense of ownership over their care, which means better overall satisfaction and adherence to those treatment plans, which of course then contributes to better health outcomes and betterment of their health decisions and betterment of their actual health behaviors. So really, I want you to understand these complex dynamics in doctor-patient interactions, from the power imbalances to those cultural influences. By exploring real-world challenges like this, you really need to gain insights into how these sociological factors affect healthcare delivery and how physicians can adopt more empathetic and communicative and culturally sensitive approaches to improve our patient outcomes and trust, because this is all really important topics. So we can dive a little bit deeper as well here. So hospitals and the role of physicians. So let's talk about this a bit further too. So I really want you all to be able to understand how hospitals are organized and the social hierarchies within medical settings and the challenges associated with physician training and shortages. So there's 4 key areas that I want to start with as we talk about this. Starting with hospital structure and hierarchy. So the typical hierarchy in hospitals, think about this, like attending physicians and residents, nurses and health staff. So these roles interact and sometimes conflict with one another. So particularly around authority and decision-making of who's actually making the decision. And that hierarchy is important to take into consideration when we look at the actual structure there. Physician shortages in education. So thinking about the Jenkins and Reddy reading that highlight the rationing of medical degrees in the United States and looks at the long-term impact of physician shortages, especially in more underserved communities. And then burnout and work conditions. So because of these shortages that we've talked about and longer working hours due to those shortages, many healthcare providers are experiencing widespread burnout, which affects mental health, job satisfaction, and then of course, patient care. So as people are just getting burnt out in their roles as providers due to these medical deserts and a lack and the shortage of physicians and healthcare providers. And then the impact of financial pressures. So again, thinking about that Barkin chapter 12 reading, discussing how hospitals are increasingly driven by those profit motives, and that often compromises patient care in favor of revenue generating activities. Thinking about the things you've mentioned, more specialized services at the expense of more general care. So be thinking about all these things and more as important contextual factors in understanding hospitals and the role that physicians have. So we'll dive into these specific areas here in the following slides. But from a medical sociology perspective, hospitals and physicians hold a very central yet complex role in within healthcare systems and society, and that both institutions are embedded within social hierarchies and professional dynamics and economic systems that really do influence how healthcare is delivered and accessed and experienced. So medical sociologists examine all of these factors and how they shape patient care and that physician-patient relationship and also broader health outcomes. So first, let's start with hospitals as social institutions. So again, in the perspective of medical sociology, hospitals are not only places for medical treatment, but also social institutions that reflect and reinforce social values and social hierarchies and inequalities. Remember way back we talked about what are social institutions, those really broad level things in society that are hard to change, but deeply embedded, even in our identity and how we view the world, how the world operates and how we operate within these social structures. So medical sociologists study hospitals' roles as part of this larger social fabric and examine how organizational dynamics influence patient care and access to healthcare. So starting with healthcare as a market economy. We've already talked about this, but again, like in the United States, as And in other countries as well, hospitals are often run as these profit-oriented institutions, and that prioritizes financial stability and revenue-generating services. And this can result in an emphasis on more specialized, high-tech treatments over primary or preventative care. And this can oftentimes leave these low-income or uninsured patients underserved. And for-profit hospitals may also prioritize treatments and services that are financially profitable, obviously, if they're focused on profitability. And that sometimes results in much more limited resources for marginalized communities. Social stratification within hospitals. So hospitals themselves mirror broader social inequalities because many hospitals cater specifically to different segments of the population based upon socioeconomic status, race, and geographic location. And this stratification impacts access to resources, with wealthier patients often having access to more comprehensive and specialized care, while lower income patients may face more limited resources or underfunded facilities, for example. And then healthcare bureaucracy and efficiency. So the bureaucratic structure of hospitals with protocols and rules and documentation requirements can sometimes overshadow the patient-centered care mission, right? And this hierarchical organization of hospitals often places hospital administrators in key decision-making roles, these folks that are prioritizing efficiency and cost control. And by putting that power into their hands, this can sometimes result in worse outcomes for patients and come at the expense of personalized patient care, because you put those decision-making priorities in these non-personalized roles and in these administrator roles. So you don't actually know the patient potentially, but you're looking at numbers on a sheet rather than that person-centered care. The role of physicians as medical authorities. So physicians hold a very unique and authoritative role in societies as gatekeepers, essentially, to health information and diagnosis and treatment. And medical sociologists study physicians not only as practitioners of medical expertise, but also as social actors shaped by professional hierarchies and economic incentives and cultural expectations. So starting with medical professionalism and the doctor-patient hierarchy. Traditionally, the physician-patient relationship has been highly authoritative, with doctors often viewed as the ultimate decision makers. And sociologists examine how this authority influences patient autonomy, patient empowerment, and how shifting cultural norms are challenging this dynamic. Today, there's much more of an emphasis on shared decision-making and patient-centered care, though traditional hierarchies still do persist, especially in these more specialized or high-stakes medical fields. And that's where, again, the intersection with the increasing specialization of care, those hierarchies continue to persist and grow. Gatekeeping and the control of medical resources. So physicians are often these types of gatekeepers that I mentioned, right? Determining patients' even access to various treatments and tests and referrals. And this gatekeeping function means that physicians play a really significant role in how resources are distributed. And that affects patients' experiences and access to timely, effective care. And so sociologists here explore how physicians' decisions are influenced by institutional pressures, such as insurance policies, cost considerations, and hospital protocols, all of which can sometimes limit or direct the options available to patients. And then economic pressures and physician autonomy. So in a healthcare system where cost efficiency and profitability are prioritized, like the United States, physicians may experience limitations on their actual autonomy. So economic pressures such as insurance limitations, administrative requirements, and the demand for productivity often influence how much time physicians spend with their patients. So the types of treatments offered or even diagnostic decisions are also weighed here. And this can lead to a sense of moral distress even among physicians who feel torn between their institutional demands, those profitability and efficiency demands, and their commitment to their patients and patient care. So it's not all just that physicians are in the wrong or anything in being a part of this system. It's that there's oftentimes this moral distress and torn nature too, of that, yes, doctors become doctors because they want to help people, right? They want to provide medical care, but sometimes there's a disagreement or a distress there between the profitability and efficiency component of a for-profit healthcare industry with the mission of these positions. Number 3, Number three here, interpersonal dynamics and the patient experience. So the physician-patient relationship is a key area of focus in medical sociology because it directly impacts patients' healthcare experience and compliance with treatment even, and overall satisfaction with care. So patient trust and communication is a key part here because trust and open communication are essential components of the physician-patient relationship. However, sociologists have found that trust can be impacted by factors such as race and socioeconomic status and prior negative experiences with healthcare. And so studies really do show that patients from marginalized backgrounds, for instance, may feel less empowered to question doctors or may experience implicit bias that affect their care. And then the sick role and social expectations. Remember, we talked about the sick role because this concept of the sick role refers to the societal expectations that we place and that are placed upon individuals who are ill. And the role that physicians play in validating and managing these roles is a critical component. So physicians have the power to legitimize a patient's experience of illness, right? And are expected to guide them back to that normal state of health. So we talked about the sick role as a role of the patient, right? That you're exempt from traditional social responsibilities and roles, and you're expected to try to get better. Well, a doctor legitimizes that illness, right? Legitimizes that, yes, indeed, you have an illness, and here's how we're going to help you get better. So the doctors play a crucial role there. And so sociologists examine how the sick role and related experiences can sometimes lead to misunderstandings or frustration, particularly for patients with, like the things we've mentioned before, with issues with the sick role, right? With chronic or invisible or stigmatized conditions or mental health conditions or disabilities. So this is really important to understand how physicians contribute to that and legitimize it and help people along their sick role journey. All right, number four, the medicalization of society. We just talked about the sick role. We also want to talk about medicalization because that is critical as well to understand. So medical sociologists study this process of medicalization as we've talked about previously. And this is, again, as a reminder, in which non-medical issues or more everyday life problems become defined and treated increasingly as medical conditions. So physicians and hospitals play a central role in this process, which can have both positive and negative implications. Think about that, right? As the world becomes increasingly medicalized, but for-profit healthcare systems increasingly want to make money, why do you think that that hospitals and healthcare providers want the world to become more medicalized? Because more treatment means more profit. So first part here, expanding the scope of medicine. So medicalization allows for new conditions and treatments to be recognized, which can be also beneficial, right, to those needing care. So for instance, conditions like anxiety or chronic pain are now treated more comprehensively because recognizing the legitimate suffering of patients is really critical. However, sociologists also critique medicalization when it leads to overdiagnosis or unnecessary treatment, which can benefit hospitals financially, but may not really improve patients' overall quality of life. There's also here the influence of pharmaceutical and medical device industries. So hospitals and physicians are often influenced by the pharmaceutical and medical device industries, which can lead to increased use of medicalizations or medications, procedures, or new technologies. And sociologists point out that this dynamic can drive over medicalization and impact patients' experiences by encouraging reliance on medical solutions rather than more holistic or even preventative approaches. Finally, the last key point here, hospitals as sites of social change and innovation. So while hospitals are institutions with, like the things we talked about, very rigid hierarchies, they're also settings for potential social change and healthcare innovation. So sociologists do study how hospitals adapt to changing healthcare policies and embrace new technologies and respond to shifting societal expectations around things like patient care. So starting first with technological advances in patient care. So advances in medical technology have transformed hospitals, allowing for more precise diagnosis, diagnostics, and less invasive treatments. However, sociologists also examine the social implications of this shift, such as how technology can depersonalize patient care or create disparities in access for underserved populations who may not have access to cutting-edge treatments. And there's a large growing area of research here in medical sociology on the use of AI in not just diagnostics now, but even surgery and new AI technology. And where did this depersonalized role come in a lack of trust potentially in technology versus a human operating on someone? And this emphasis on preventative and holistic care too. So some hospitals are beginning to emphasize preventative care and holistic approaches to health, recognizing the role of the social determinants of health more. And so this reflects a shift in understanding that health is influenced by not only biology, but by social, economic, and environmental factors. And so sociologists, like all of you, like all of us, view this trend as part of the growing recognition of the need to integrate community-based and interdisciplinary approaches within hospital care, like all of the things we've talked about before this day. So just in conclusion, medical sociology's perspective on hospitals and the role of physicians emphasizes the social, economic, and institutional factors that do shape our healthcare delivery and experiences, because both institutions are powerful social actors that influence and are influenced by these broader social inequalities and cultural values and economic pressures. And so by understanding these dynamics, medical sociologists contribute insights that are really critical to addressing disparities more holistically and addressing disparities in healthcare and creating systems that better serve diverse patient populations. Just in summary and in closing here, again, think about what I want you to understand and be thinking about critically is the structure and challenges of the American healthcare system. And, in 45 minutes, we can't get into all the nuances because it is an incredibly fragmented and nuanced system. But hopefully the readings and the videos and the applications here help to chip away at that understanding. And then I want to also emphasize the importance of doctor-patient interactions and how those social factors influence these relationships and overall health behaviors and quality of care, quality of health outcomes. And so I also want to reinforce how hospital structures and physician shortages have impacts and continue to impact healthcare delivery. So be considering how all these things might shape, your potential future interactions with the healthcare system or your future interactions with potential patients that you may have or your interest in healthcare careers. And just two last things, I promise, two last final things. Your next class period, we do not have a recorded lecture setting, a formal recorded lecture setting. You're going to it's actually more self-direction time. So all I want you to do is view this panel at the Future of Health Summit from 2023. The link is right here. It's also in the Moodle page, link directly to the Moodle page. It's an interesting discussion on social epidemiology and public health and social movements. So take a look at that. And then an assignment reminder too. So again, just a reminder again, your second paper is due by the end of day Sunday, April 6th. So if you have any questions about that assignment, about the next class period, about this class period, about previous, whatever it is, I'm happy to meet one-on-one as always. Please let me know of any questions you have. Thanks again for tuning in today as always. And then I will catch you next time.